Hello everyone, my name is Dr. Amar Pal Singh. I'm a Consultant Cardiologist at London North West NHS Trust, and today I have a talk about cardiac imaging. As you may imagine, this is a very large topic, so we have split these talks, with the first one today being about the basics of cardiac imaging, and then subsequent talks about more advanced techniques that we use and the clinical applications of the imaging. So without any delay, we'll go on to the first slide. The first thing to note, I think, is very important that if you want to learn about imaging, cardiac imaging, you have to understand the principles. So to use it at all, we really do need to understand the principles. So the principles of how the things work are much more important than the details. So we'll try and concentrate on the principles to begin with. As I said, the next parts will deal with advanced techniques such as stress echo, perfusion, imaging. And then eventually we'll go on to talk about clinical applications and actually how we use imaging currently, which is probably a combination of many things together. So starting with the most simple thing, an X-ray. What is an X-ray? If we look at the electromagnetic spectrum, which just means all types of electromagnetic energy, including visible light, which you can see right there, almost in the middle of the spectrum. X-rays fall just to the left as you're looking on the graph, and they just represent a different frequency of electromagnetic energy. Whilst we tend to refer to all of these things as waves, it's actually important for how they work to understand that electromagnetic energy comes in little chunks, in little packets called photons. So how do we generate an X-ray? So the simple way of understanding it is that you heat up a block of tungsten, and when you heat up a block of this heavy metal tungsten, it releases electrons. And so we enclose that inside a vacuum chamber, and electrons are negatively charged. So we provide a battery to make it very negative on one side and positive on the other side. And we enclose it inside the chamber, and therefore the electrons are accelerated towards the positive end. And in fact, they actually reach about half the speed of light by the time they hit the other end, which also happens to be a block of tungsten. So you heat up tungsten, you generate electrons, you speed them up to half the speed of light, and you smash them into another block of tungsten. And what that does is generate photons in the correct wavelength that we need, which is the X-ray wavelength. So we've generated these X-ray photons, and as you can see from the machine, what we do is shoot them into the area of interest. So in this case, this gentleman's right arm, and some of them go through, some of them are blocked by different types of tissue. So you get effectively a map of different intensities, and you can see that you can therefore make out structures like bone. Having understood what a basic X-ray is, let's talk about what a cath lab is. The central part of cath lab is basically a tube that is firing X-rays, which is left on for a few seconds. So if you take multiple frames of X-rays, so we saw a single frame before, we take multiple frames of X-rays and put them together, you effectively get a movie. Technically, we call it a cine. That technique of putting multiple frames together is fluoroscopy. So if we look at the cath lab setup, the X-ray source this time is actually below the patient. And the X-ray photons are fired upwards, and then they're collected at the top end, and lots of frames are put together to make the cine. Together with that, we have another concept where we use something called contrast. So we use an X-ray opaque substance to reveal certain structures that we are interested in particular. In this case, obviously the coronary arteries. So we inject contrast, which lights up the coronary arteries, and then we can shoot X-ray, and we can see the coronary arteries in clear detail against the background of all the other tissue in that part of the body. And so you get a picture like this. And for those of you who are not familiar with catheter angiography, we've got a very severe lesion in the middle of this gentleman's left anterior descending artery. And when we put the frames together, we produce these cines, and this is what we actually see and use in the cath lab when we're doing it in real life. And what you've got is pictures on one side of the left anterior and the left circumflex artery, and then on the other side of the right coronary artery. So we go onwards to CT, to give us its full label, computed tomography. And this is effectively taking lots of X-ray frames across a volume of space, and then combining all that data together to produce a model. So if we look at how the CT works, you have an X-ray source, as we saw before. It shoots X-rays down through the body, and you have a detector source. But actually in CT, what happens is we spin it round, so you can take lots and lots of pictures as it turns round, so you can build up a 3D model of the body. A tomogram is a technical term that we use for that sort of 3D model that we build up, and therefore that is what CT refers to. A computer that takes lots of frames and computes it into a tomogram. And this is what we get for cardiac CT. So again, you're looking at roughly the same structures that we were looking at before. You can see all three coronary arteries as it looks like when we take a CT picture. If we go back over how we use X-ray, you shoot X-ray photons. And when you do that into a single frame, you get a plain film X-ray. And if you combine lots of frames over time, you can make a cine, and that's fluoroscopy in the cath lab. And if you combine lots of frames in a sort of 3D model that a computer puts together, you get computed CT, and we use that for cardiac CT. And the other principle to remember is we can use contrast to delineate the structures we are particularly interested in. So onwards to another modality. So we've done X-ray, that's the first one. So onwards to another modality. So sound. So what is sound? It's just waves of varying air compression. That's what sound physically is. And so if you wanted to plot these waves and in terms of pressure, so you have waves that are very close together, and you have waves that are very far apart, and they occur cyclically, and that is what a sound wave is like. And you can plot it as a graph, and you see the typical wave-like pattern, and which is what your ear then hears and converts into electrical signals that you interpret as sound. So what's ultrasound? Well, ultrasound simply refers to sound waves that are above the human limit of hearing. So if you're about 20 years old, that is about 20 kilohertz. For the rest of us, it's quite a lot lower, probably down to 15 kilohertz once you're in your 30s and 40s. And this is sort of akin to the electromagnetic spectrum. This is just a sort of sound wave spectrum, if you like. And you can see there's what we hear as sound and noise in the middle. And then there's ultrasound just above that to the right in the diagram as you're looking at it. So ultrasound, or when we use it for cardiac applications in the heart, as we call echocardiography. How does it work? The basics are that we vibrate a material surface, and if we vibrate the material surface, it vibrates the air that's right next to it. And that vibration then produces a wave that we saw in the earlier diagram. How do we do that? Well, it turns out that there are certain materials that deform when you apply electricity. And that class of materials is called piezoelectric. What's important to understand is that it works the other way around as well. So if you take a sound wave and shoot it at the material, it will generate an electrical waveform from the sound wave, just as putting an electrical waveform into the material will generate a sound wave at the other end. So if we look at that in this diagram, the piezoelectric materials, if you look in the bottom right of the diagram, we put in some electricity into these materials. It generates a sound vibration, and then those sounds are shot into the human body, and they're reflected differently from different tissues. So the sound waves reflected differently by different densities of tissues, and therefore we can build up a picture of those different structures. And then what actually happens is we measure the reflected. So it goes down, hits the tissue, reflects back, and the way we measure the reflection is simply to use that same piezoelectric material to generate a little electrical signal. In real life, the probes now have several of those piezoelectric material in a row, so it can put out multiple, as the diagram illustrates, multiple lines of sound waves at one time, and therefore generate a sort of 2D, even 3D in a grid-like pattern of crystals, 2D or 3D picture straight away in one go. And so you're seeing that here. You're getting the multiple sound waves reflecting against a structure, and therefore you start to see things like, say, the wall of the ventricle. And this is what we get. So I have deliberately picked a very real life case. This is not the best textbook case of echo that you'll see, but this is very typically what we actually get on the ward to look at when we have inpatients. And once we've generated these ultrasound echo pictures, we can do some advanced things with them. So this is what I'll cover in a future talk, but just very briefly, we can use physical principles like the Doppler effect and the law of conservation of energy to not only produce pictures, but to also measure things like the gradients across a valve, the size of the open valve, as illustrated in this diagram. But we will come back to the principles of how these work in the next talk. So let's go onwards. So we've done two modalities so far. We've done X-rays and we've done ultrasound. So let's go on to MRI or magnetic resonance imaging. Now, unfortunately, compared to X-ray and ultrasound, MRI is a lot more complicated. So I'm going to go through this very slowly and step by step, and hopefully we can all follow along. So MRI requires excitation, sometimes called resonance, of atomic nuclei. So in the human body, it turns out that because we're mostly water, the most abundant nuclei are hydrogen nuclei, because the most abundant atom is probably hydrogen atoms. So for human MRI, we use hydrogen nuclei. And if we look at a hydrogen atom, the nucleus is just a proton with the electrons sort of spinning around it. And so if you think about what a hydrogen nucleus is, it's just a proton. So when we say we're using nuclear resonance, if we take hydrogen, it turns out we're just really referring to a proton, which sort of makes it more simple. So a hydrogen nucleus is literally just a proton. So as I said, for human MRI, we use hydrogen nucleus imaging or proton MRI. And the basic concept is if you put protons in a magnetic field, they all align their quantum energy states. Now, I've said quite a big word, quantum energy states there. It doesn't really matter what that is. The main concept is that they have a property of protons called their quantum energy state. And if you put them in a magnetic field, they all align. They all align together. How do we generate that very powerful magnetic field? So actually what we do is use something called a superconductor. So a superconducting material, which generates a very powerful magnetic field when it's spinning round and round. So we've got a sort of toroidal structure. You fill it with this superconductor material, it spins round and round and generates a very large magnetic field. And if you see in the diagram in the bottom right, the patient goes inside what is basically a big donut filled with a superconductor and with a very generating the very large magnetic field. That magnet is always on. So because the way in which you generate it requires the superconductor to carry on going round and round, so that entire structure is continuously going round and round. And that means the magnet is always on, whether we're using it or not. It's a continuously very powerful always on magnet, which is one of the safety considerations with MRI. So let's see what's going on. So we apply a very large magnetic field, and all the protons in the magnetic field align their quantum state. Now, there's actually two states that proton can take, high or low. So if you look in the diagram below, we have all the protons, which are arrows, sitting there before you apply the magnet. You turn the magnet on, and then they have to align to either high or low relative to the magnetic field. So that's what the diagram is showing. Fine. We then apply more electromagnetic energy. So we've got the main magnet, and we now apply more electromagnetic energy using a secondary and accessory magnet. So you can see it says apply proton-specific electromagnetic energy, or and at the bottom it says RF magnet. So that's the accessory magnet that is applying the extra electromagnetic energy. And what you see happens is that some of those protons that were in a low quantum state get excited, or they resonate, and they resonate up to a high quantum state. So that's what the diagram is showing you. Okay, so huge magnetic field, protons align, and then you put accessory energy in, and the ones that are at a lower quantum state go to a higher quantum state. And that's what the resonance out of magnetic resonance imaging refers to. And then what do? Well, we turn off that accessory EM energy. So we turn off the additional energy that we were shooting into the area, and then all those protons that were excited up to the high state fall back to the low state again. And that then emits the energy that was pushed in, was then emitted back out again by the protons, and that energy that comes back is picked up by our magnets, the same magnets that we use to send it in. The energy is picked up by our magnets, and that is the MRI signal. That is the actual information that we use to make an MRI image. So if we look on the diagram, we're going to start from the left and go to the right here. Okay, so we turn on the main magnet, the big huge magnet. We don't turn it on. We put the patient inside the big huge main magnet. Then the protons align to a high or low quantum state. We then turn on the accessory RF magnet and put in more EM energy, and some of those protons resonate to a high level, and then we turn off that accessory RF magnet, and some of the protons that were resonating in a high state fall back to a low state. When they do that, they emit some energy. That energy is detected, and that energy is our MRI signal, is the signal that we use to construct the MRI picture. The reason we do this is because in every tissue, the rate at which that signal is emitted, the rate at which the protons relax, is different. So that means that we can now literally have a map of different tissues, which is basically what MRI gives you. It's very good at tissue differentiation. You can separate fat from muscle, from bone, from water. And then an additional technical term is that we use yet a third set of magnets in a sort of XYZ plane to triangulate where the signal is coming from. So if you think of sort of a mobile phone and you have 3 masts, and you can tell from 3 masts, you can triangulate where a mobile phone is because it might be closer to one mast than the other. This works in the very same way. You have an additional set of 3 magnets, and you can see what is called the Y coil, the Z coil, and the X coil, and those just allow us to pinpoint exactly where that signal is coming from. So it gives us the spatial information that we need to accurately make the MRI map. Okay, so that was a lot of information, but I hope it's sort of clear how we actually generate an MRI signal. If we go to cardiac MRI in particular, our main issue is how to get enough of that signal. So when protons go between quantum energy states, the actual amount of energy, the amount of signal is very, very small. And so what you generally have to do is just turn the scanner on for a long time. So if you have an MRI of your knee, what you'll find is your knee goes inside the scanner, you turn the scanner on, let it be there for 25 minutes, and then take your knee out. And you've acquired lots and lots of MRI signal. We can't do that because the heart moves while it beats, and the heart moves because you're breathing. So we can't use that technique where we just acquire lots and lots of signal by turning the machine on. So the way to get around that is to ask the patient to breath hold, which takes away the movement from the chest cavity while you're breathing, and then to acquire the signal at the same time in the cardiac cycle, and then average them all. So the breath hold tries to take away the breathing movement, and then to take away the cardiac cycle movement, we just acquire the signal at the same time in the cardiac cycle, and then just average that all together until we get enough signal to make a picture. Now, if you imagine we are doing this while the patient is breath holding. So the total number of cycles that we can average together is limited by how long you can hold your breath. And of course, remember that when we're doing MRI, we're not doing it on young, healthy patients. We're doing it on people who've already got problems with the heart and may already have difficulties breathing. So you can see that we are definitely up against it in terms of getting good MRI signal in cardiac MRI. It's one of the main issues that we work with all the time to try and get around, is how do we get good pictures when we're limited by how long someone can hold their breath and how many cardiac cycles that we can fit inside that breath hold. So this is the picture you get. And as I said before, this is a cine. So as I said before, if you just acquire lots of frames over time, then you can make a sort of movie out of it, technically called a cine. And what you can see here is 4 cines that are done at different slices through the heart. So we call this a short axis, but you can just imagine we're just sort of slicing horizontally through the heart. And so the circular structure with the black outline is the left ventricle, and that black outline is the thick muscle of the left ventricle, and then the structure that sort of is on one side but wrapping over it is the right ventricle. And of course you can see that the muscle layer is much thinner. You know, the right ventricle muscle layer is almost paper tissue thin, and the left ventricle has a proper thick muscle. And again, for those of you who don't do cardiac MRI, if you look in the diagram, so if we look on the top left one and we look at that circle of muscle, if you look towards the top left, you can see that it becomes white, and that is the MRI signal telling us that there's infarct in that area. And if you look closely, you can see that whilst the other bits of the circular muscle are contracting inwards, that white area isn't barely moving. And so that is infarcted muscle that we're looking at on MRI. Let's go on. The fourth and final modality that we use for cardiac imaging is a nuclear scan. So I'm certain we've all heard of or even ordered nuclear scans. So let's get it out of the way first. When we say nuclear scan, we're not referring to MRI. What we're referring to is 2 interrelated scans, PET and SPECT. Okay, so let's go on to what that actually is. So a nuclear scan, what does that actually mean? So we take a radioactive molecule. So radioactive just means a molecule, just means that you spontaneously emit EM energy. So you take a radioactive molecule that spontaneously emits EM energy wherever it goes, and you attach it to something in the body that's already there. So you attach it to a peptide, you attach it to an antibody. Then you inject that back into the body, and then you can follow the activity of that, say, antibody just by scanning for radiation, because you've now attached the radioactive molecule to the antibody. So a nuclear scan is effectively the detection of EM radiation from that radioactive tracer that you've attached to something in the body. And we've got 2 types of tracer. One is a tracer that emits gamma photons. And if you use that sort of tracer, you're doing basically what is SPECT. And if you have a tracer that emits positrons, you're doing what is PET. So again, these are technical terms for these particles. It doesn't matter too much, but there are 2 separate types of tracers that we use. One is gamma photons that produces a SPECT image, and the other is positrons that produces a PET image. So if we look at where we are, in terms of what gamma photons, so you'll see it's just, again on the diagram, just the left of X-rays. So gamma photons are much like X-ray photons, they're just at a different frequency. So let's go back to SPECT. So we said direct detection of a gamma photon from the tracer. So it's called single photon emission CT. That's where the SPECT comes from. So we are detecting the emission of a single gamma photon, and then we are computing all that information into a tomogram. And so it's ended up being called SPECT, SPECT, which is where you get it from. So if we look at it diagrammatically, you have a radio tracer that you've injected into the body. It emits gamma photons. You have a camera that detects gamma photons, and you actually use the camera at various different angles, as you can see in this picture. And again, like the CT, you use the camera in various different angles, and you compute a 3D picture out of it. So you compute a tomogram, so it's CT. So really, you could think of SPECT as gamma ray CT. And when we say CT, we tend to refer to X-ray CT. SPECT is really gamma ray CT. So PET, what is PET? Well, as we said before, if you use a radio tracer that emits positrons, we detect the emissions of positrons. So positron emission tomography, PET. The detection of positrons is actually slightly more complicated. So you have a radio tracer, it emits positrons. What actually happens is a positron decays into paired photons, and the pair is detected in the camera. So what you need, so you can see here, you have a positron emitting radio tracer, emits a positron, and then that positron turns into a pair of photons. So what you need is a much more sophisticated camera that can detect pairs of photons. So you can see there the diagrammatic thing. So there's an event inside the body where the positron turns into photons, shoots off its sides, and then the camera only detects a signal when both photons hit at the same time. So it detects opposing pairs of gamma photons which come from a positron. The actual machine looks very much like very many of our other imaging devices that have to go round in a circle. So it basically looks like a CT machine, but that is what it's doing. So cardiac nuclear medicine, what do we specifically use nuclear medicine in cardiology? Generally, there are a number of things that we could use it for. Generally, we use it to follow blood flow. So perfusion. So we use it to follow blood flow through different parts of the heart muscle. And as I said before, PET is a newer, more sophisticated method. This actually typically takes 30 minutes, but it requires a very expensive machine, and therefore it's much less available than the older method of SPECT, which actually takes a couple of hours. But depending on where you are, if you refer a patient for a nuclear medicine scan of the heart, you will often get a SPECT scan. But practice is evolving, and I suspect soon we will only be doing PET once all the centers upgrade to the higher machines. In actual fact, if you look at the pictures we get out of it, we get very similar pictures out of it. So you can see both a SPECT and a PET scan. So these are the pictures we get out of it. It doesn't really matter too much from clinical sides which one you're using. And if you look, what we're looking at is it's a diagram that's very akin to the MRI image. That ring of light that you see is the left ventricle. So it's basically a ring of signal from the left ventricle. And if you look at the resting images at the bottom, so this is just when the patient is at rest and normal heart rate, you see so let's look at picture 12. You see a nice round ring, a nice round donut, and then you apply stress. There are various ways of stressing the patient, and we will talk about stress in another talk. But we apply stress to the heart, and then what you can see, I think best illustrated in picture 13, is that one part of that muscle is not showing that very light orange blood flow that the other parts of the muscle are. So at rest, all the muscle blood flow seems normal, but when you stress the patient, one part of the muscle is not getting enough blood supply. And that indicates that there's probably a narrowing in the artery that supplies that part of the muscle. So we've done lots of technical terms, lots of acronyms. I think the important thing is it's the principles rather than the details. The details you can always look up at any time should you need to do them, but it's the principles. So cardiac imaging works by, if we look at this last slide, cardiac imaging works by the differential response of tissues to one of four things. The transmission of X-ray photons, and that gives us X-ray, CT, and the cath lab. The differential response of tissues to reflecting air pressure waves, that gives us echocardiography. The differential response of tissues to excited protons and how quickly they relax. Resonating protons, how quickly they relax, that gives us cardiac MRI. And then finally, the differential response of tissues to emission from a radio trace, and that gives you PET and SPECT. I have also obviously just marked on there which ones have got ionizing radiation. So that's X-ray, CT, and nuclear. I've got ionizing radiation, so that's something to keep in mind. And we'll talk about how we select which imaging modality in a further talk. But coming back to the principles, there are different ways of imaging tissues. The 4 ways that we've talked about. We can do multiple frames over time, producing a cine. We can do multiple frames in space and compute it all together in a tomogram, which we call CT. And we can use contrast to delineate certain structures of interest to us. So, for example, the coronary arteries. I'm going to stop there. I hope that you have a better understanding of imaging and cardiac imaging in general. And we will come back to this in our later talks. Thank you.